Good afternoon and welcome to September's CDI Innovation webinar, where we're going to talk with VCU today and how they have that value story with our CDI Engage One. We're really excited and very honored to have them here. Before we get started, I'm going to go over a couple housekeeping items. We are utilizing the On24 platform. This is a web-based platform. So if you are experiencing any audio issues, just do a quick refresh of your browser. That usually clears anything up. In the other engagement tools in the media player, if you do need closed captioning, that is available. We do have a resources section, so make sure you take a look at that. We are offering our presentation today, and I'm very excited to say we are offering CEUs today. Normally, we are only able to provide a certificate of attendance, but because we've had this presentation at our recent CES conference, that is carrying over to today. So very excited about that. So be sure you download that CEU certificate of attendance. We also have a Q&A section. We encourage you to answer or ask questions throughout. We'll answer as many as we can at the end. And then lastly, we do ask that you complete the survey at the end. We really appreciate that. And so to get us started today, again, we do have two great presenters from VCU. If you do want to read more about them in the Meet the Speaker section, you can learn a little bit more about their bios. But I'm going to go ahead and pass it over to our speakers today. Alison and Emily, thank you for joining us, and I'm passing the mic over to you.
Great. Thanks for having us. Very simple agenda that we're going to go over today, but really highlighting the Solventum CDI Engage One initiative that we took on at VCU Health, some timeline, and then, of course, the outcomes of that implementation. Of course, leaving room for questions and answers at the end of the presentation. Oops. To get us started, I found a few quotes that I really thought set the stage for the presentation and really leveraging the technology that's available at our fingertips as we continue to evolve with Solventum and the CDI world itself. Innovation distinguishes between a leader and a follower. AI is the defining technology of our time. It's up to us to use it responsibly and with ambition. The measure of intelligence is the ability to change. So while we're highlighting VCU, we also want to make sure that everyone understands that we're a part of a bigger organization, Ensemble Health Partners. Ensemble Health Partners is a healthcare revenue cycle company that provides services in a number of different revenue cycle areas, as well as the CDI space itself. So that's where Emily and I as CDI leaders come in to partner with various clients and their CDI initiatives. This is just a very high-level overview of the scale and the ability that Ensemble has to provide those CDI services and really leverage the technology that's available to us, people, resources, as well as standardization in the CDI space.
And so then speaking a little bit to VCU Health, VCU is in Richmond, Virginia. We're a comprehensive academic medical center that has over 1,000 providers. We're a level 1 trauma center. We do have a burn unit. We do transplants, recently added on another transplant service line. And of course, with all of that comes a large focus on quality measures. But one thing to keep in mind is we do have to have the appropriate reimbursement to both fund our research and to serve the vulnerable populations that we serve. So when we talk about technology, obviously it's important in CDI and healthcare in general, but even in our daily lives, thinking about how technology has impacted us. I've recently rented a car, and it had, the Apple Play and the adaptive cruise control and everything. And it was my car is 10 years old, so it doesn't have all this technology. And so it was a really nice drive having that Apple Play to easily go to my Audible or my music. And then also having that adaptive cruise control, that was really interesting. So then thinking, how does that translate into CDI. You know, if we think about where we were at with chart reviews 10 years ago, focusing on the CCs and the MCCs and not having all the quality measures and everything, you know, our focus was quite different. Now that our focus is so large, we really do have to use technology to help us find all of those different nuances of the chart. And so adopting this technology has helped us strengthen our relationship with the client by providing that consistent quality care. So going to Engage One, like, how did we implement it? We really did have to have all hands on deck. So everything from our CDI team, of course, they're the subject matter experts. They know the workflows, they know what's going to work well for CDI and what's not. And then we have two really great physician advisors. And so they were able to advocate for the providers on documentation, anything from how does, you know, dismiss versus disagree read to a physician, you know, versus how we deliver the queries and what that will look like in their workflow. So having them involved was very helpful. And then IT resources, there's nothing listed because it's everything, right? I think we all know that. They work their magic in the background. They make sure all those interfaces are there. They do all the testing and they do all the things that I don't know. It's the magic behind the scenes. So of course you really do have to have them involved. And then not leaving out our Solventum partners, they helped guide us through the whole process and really helped us with our timelines, training, education, and the selection of our evidence sheets and everything. So at this point, you might be going, okay, but I don't even know what Engage One is. So we're gonna step back a minute here, and we'll go through it. So Engage One is a CDI platform, uses artificial intelligence and natural language understanding to really enhance how we review the chart. There's 3 different phases kind of that go live. And the first phase is really the evidence sheets and enhanced prioritization. So when we think of evidence sheets, we think this artificial intelligence is reading through the chart. It's pulling out things from the progress notes, from the lab work, any vital signs in those notes, medications, and it's pulling all of this together into a nice little package for CDI to review. So if you have a heart failure evidence sheet, it's looking through and looking for kind of that lower extremity edema, the, you know, crackles on the assessment, what's in the chest x-ray, was there some pulmonary edema there, and, you know, any medications, was Lasix given, and it'll pull all of that into a nice little evidence sheet for CDI to review. And then we can add prioritization to those evidence sheets to determine, you know, if there's documentation opportunities. So then query delivery itself, this is a more automated query delivery system. It does take the queries out of the physician's inbox in the electronic health record, so reducing that burden. As we know, those inboxes can get really overwhelming. So it does pull it out, and so it's a nice little separate area. As a CDI, when we see the evidence sheet, we can link it straight to a query, say, yes, this patient has heart failure, looks like they have acute on chronic systolic, but the doctor's only documented heart failure. And so now we're going to send that query. Now, I'm a really fast typer. However, I cannot type as fast as I can check and uncheck a box. So that as you write these queries, you can check and uncheck a box to pull in those clinical indicators straight into your query that were pulled from the evidence sheet. And then that query gets sent directly from the Solventum Engage One system to the provider. On the provider side, it pops up and they can take a look at it. They can see your whole query. And on the side, it's really easy radio buttons that they can select yes, this patient has acute on chronic systolic heart failure. That response then comes back to CDI and goes into a note in the electronic medical records. So all of this, also query responses can be prioritized. So making sure CDI gets back to those records quickly. And then the third piece is our computer-assisted physician documentation nudges. So this is where we start moving from being reactive to being proactive. So while the physician's actually documenting, and they're documenting, you know, this patient has heart failure, a pleasant little pop-up comes up and says, you know, could you specify the type of heart failure? And so while they're actually still in the note, they could go, oh yes, I can write in acute on chronic systolic heart failure. And then they don't even have to get that query on the back end. So that's the great part about the nudges. It's really moving into that proactive space. So here we look more at the technical workflow of the Engage One. And one thing I do want to point out is, you know, CDI may not review an inpatient record until 24 hours after admit, but those nudges can be firing even before CDI has touched the chart. So that is really nice, is even if CDI didn't, you know, the patient got admitted Friday afternoon, and if your CDI department doesn't work the weekend, that nudge could still be firing and working in the background before CDI comes in on Monday and gets to the chart. And so this does integrate with the CDI, the 360 Encompass system. So it really brings everything all together. So I'm not going to read line by line here, but this is our general timeline. One thing to point out is January of 2024 is when we went live with our evidence sheets. So we went live, and then every few months we added on an additional 3 to 5 evidence sheets. And then in April, we started our query delivery process. So moving those queries into straight out of Engage One to the physicians. And in June, we finalized our prioritization. That took a lot of customization, making sure it worked well for our patient population and documentation. And then in August, we added on the nudges, and you can see all the additional evidence sheets here. So I mentioned this a little bit as we talk through Engage One. You do have to keep in mind you can tailor it to your facility and documentation. So really that evidence sheet governance lies with the CDI team. So actively reviewing those evidence sheets, listening to the team's feedback, and getting rid of some low value nudges. So I think go live of evidence sheets, we found very quickly that anemia evidence sheet was firing very often and not often kind of requiring a query. So we did disable that one to reduce the noise for our team. And then like the stroke one, it just didn't work well with the way our physicians documented, because they often said, you know, in their beginning statement, the patient had history of stroke, and it was picking it up as a more current diagnosis. So, you know, you do have to evaluate how it works for your documentation, and getting that feedback from the team is really helpful. And then also working with your Solventum partners there. You know, there are things that they can do on the background to tailor those evidence sheets as well to make them work for you. So, and then with the evidence sheet, you could turn any of those into a nudge. You could turn most of those into a nudge for the physicians. So seeing does it work well for the team? Does it often get a query? And is that, you know, something that you would want to then move into that proactive space? We did have to redesign our query templates. So we did standardize query templates. That was actually a bigger project across all of Ensemble. So we had that project as well. And then customizing our nudge logic. So just like we listen to the team feedback on the evidence sheets, we also listen to the physician and the provider feedback. So when we first started with our nudges, we had a heart failure type and acuity nudge, and the providers said it was really hard for them to satisfy that nudge. So we moved it to a heart failure type only, looking for that systolic or diastolic. And we save the acuity for a CDI query. If they don't add the acute on chronic, then CDI can still send that query. So here's the list of the various evidence sheets that we turned on. And now we're going to get into some data. So our workflow rates. Here, I'm just going to caveat to say the actual review rate is on the overall and not just our scope. So, but we stayed pretty consistent with our review rate throughout the entire process, with one dip at prioritization. And then you can see the blue lines, that's our query rate and visit query rate. Those steadily increased after the initiation of the evidence sheets. So you can see those going up over time as well. So talking about the effect of prioritization on our review rate, I think we know anytime you have a change in workflow, you may see impacts to metrics. And also keeping in mind with prioritization, you do have to tweak it. And so making sure that you make it work for your patient population. So we saw 1 month dip with the prioritization go live, and then we were able to make changes both with our workflow and also with the prioritization to make sure we were meeting our goals. Then adding in our queries with impactful diagnosis codes. So fancy way to say we added CCs or MCCs to the records. And so you can see over time, again, increase in the number of CCs and MCCs that were added from our queries. And then how many of our visits had CDI financial impact? At the time of evidence sheet go live, we had about 159. And then by March of 2025, we were, 270. So definitely making financial impact on more cases. And then going into the actual numbers of what that looks like, right, is our estimated financial impact. So with our evidence sheet go live in January, just before that, we were just under $1 million or just over $1 million, 1,043,000. And then by March 2025, we were 1,548,000. So definitely making more financial impact as well. And then here's one where you actually do want to see the numbers going down, right? So this talks to the efficiency of the CDI review. So how many times or how many charts does a CDI need to review before they find a query opportunity? And so prior to our evidence sheet go live, we were, 8, 9, 10 charts before we found a query opportunity. And then as we've added on more evidence sheets, that number has definitely come down over time. So definitely talks to the efficiency of that review. We've talked a lot about numbers and financial parts, but I've already mentioned the quality aspect of our work, right? So looking then at our quality indicators. So with VCU being a comprehensive academic medical center, we do have 3 facilities within the overall umbrella, and they all use different quality measurement tools. So some use Vizient, some use Premier, Leapfrog, so we do have to keep in mind that. But one great thing is there's so much overlap between the different quality measure groups. that we're able to use that Elixhauser that's built into the Solventum system to really help us kind of keep a gauge on a lot of that. Our Solventum partners were able to pull out what evidence sheets were likely to impact your Elixhauser measures. And you can see just by the numbers that we've definitely made an impact there. And then also, not going to say the HCC markers, we didn't go from 0 changes up to 500. There was a issue with the technology not being turned on. So we did get that turned on in October so we could track any changes with our HCCs as well. Then keeping on that quality side, our APR DRG query impacts, so that increasing of the SOI and ROM has, of course, gone up with that as well. So since our evidence sheet go live in January, we've definitely seen an increase over time for both the SOI and the ROM shifts. And then this slide, I know some of it might be a little hard to see. This comes directly out of the enterprise analytics in Solventum. So I mentioned when we have evidence sheets, you can actually start a query straight from that evidence sheet. Those are called linked queries. So this gives us some linked query trends. So you can see how many of all of our queries were linked to evidence sheets. So still we're sending a lot of queries that the CDI are finding outside of evidence sheets, but the ones that are linked to those evidence sheets do have a higher agreed and documented rate. So 89% of the linked queries come back as agreed and documented compared to 84% of the unlinked queries. So I do think that that speaks a lot to those clinical indicators that are pulled in and the ability of the evidence sheets. And then 99% of those queries do end up impacting the final code set of the linked ones compared to 90% of the unlinked queries. I am going to hand it over to Alison.
Great stuff, Emily. Thank you for sharing. So as we move forward, Emily went through a whole lot, right? The initial go live, what Engage One is and how it works from a technology perspective, and some of those incremental improvements month over month. What I'm going to do now is break it down and do that comparison, right? How are we pre-Engage One in prioritization versus post? You can see as Emily went through that there was a lot of different elements that go into the overall output of what we're seeing as far as improvements at VCU. Not only was it just the evidence sheets alone or just implementing prioritization, but engaging, right, our physician advisors and partnering with our CDI team to look at what is going to work best in order to make those incremental improvements for the organization. This is a tongue twister here, so just keep in mind when we go through the comparison period, right, just to really look at the pre and post of what we were really targeting from go live. We're going to look at April of 23 to March of 24, and then April of 24 to March of 25. So just keep that in mind as we move forward, so I don't get tongue twisted as I keep saying it. So a lot of this information Emily shared in that month over month improvement at overview and trends that she showed. Here we're going to look at that year over year comparison and really look at, you know, what is that true difference that we're seeing overall. So from a financial impact perspective with the queried visits and their impact overall, we saw a 30% improvement in the CDI financial impact. So again, that's almost a $351,000 month over month improvement, as well as the percent of queried visits and their financial impact improved by 4.5% as well, right? This isn't to say that the team wasn't doing a good job before, but again, using technology to be able to take some of that lift off, right? Identifying some of those evidence, really preemptively nudging the providers, prioritizing cases. So I'm not looking at cases that don't have an opportunity for improvement first, and then maybe missing some of those higher prioritized cases for later in my day or later in the week. So again, just kind of offsetting the workflow really lends to what we're seeing from a financial improvement perspective. Next, then the financial impact in CDI visits, just the pure volume alone. So again, that difference we improve from previous period to current period by 74, which is a 45% increase in the average monthly visits with financial impact. So again, just adding on 74 additional cases that have that added impact as well led to what we see, that $351,000 impact, and then that month over month continued improvement. Now, do we expect it, right? We keep everything the same. Do we expect to continue to see this moving forward? No. This is our big bang for our buck impact by implementing this technology. Now, as we continue to refine the evidence sheets that are available, the nudges that we're giving to our providers, we may see ebbs and flows to these impacts that are available to us as well. Looking then at the impactful diagnoses, or that CC and MCC capture. So again, CCs added, that difference was almost 63%. The MCCs added 70%, for a total added percentage of almost 67% from previous to current period. So again, we saw that kind of evolution and increase in trend that Emily showed us. And here's, that big year-over-year impact that we were looking for. Looking at the CDI reviews to net queries, as Emily mentioned before, right, this is where a decrease is a good thing. How many reviews is a specialist needing to do before finding that opportunity? We were able to decrease the time. So, right, improve efficiency, improve the availability for the CDI specialist to work with the providers, to engage and make sure queries are being answered timely, to do education, to really start other initiatives in the CDI world at VCU Health. We were able to decrease the amount of reviews to queries by 32%. So that's a huge improvement, right? Using the evidence sheets to hone in on the available clinical indicators, risk factors, and treatment that are necessary in a query, as well as then prioritizing that case. So as I'm reviewing it, I know that I likely have an opportunity to improve the outcome of that DRG. SOI and ROM impact, right? Huge quality initiatives across many different healthcare organizations. And, how are we driving that change when it comes to SOI, ROM impact, and the quality indicators there? So just reviewing the visits, and then the average monthly visits with SOI and ROM impact from previous period to current, we improved the ROM by 70% and the SOI shift by 64% as well. Huge shift. Looking at the nudges that were enabled starting in August of 24, we reviewed this previously, right? So again, there's going to be ebbs and flows, and technology isn't flawless when we implement it, but making sure you're making iterations and really looking at it holistically and making sure it works for you and your organization. So we initially at the outset put out the type and acuity of heart failure. The read and the feel of that based on our providers was that, it wasn't working for us. It was too cumbersome to work through. And so we refined that to just go after the type of heart failure only, and allow that if that acuity is needed, the CDI specialist would generate that query. Hypoxia was another nudge that we went after, malnutrition, encephalopathy. And then one that, again, we leaned into our physician advisors for, and they helped us add this one to the nudge go live, was midline shift or mass effect. This is just an example starting point, right? You may look at your organization and target different nudges that you would deem effective for your organization. And so that's one thing in your partnership with Solventum that you really need to look at closely. Where are we going to get the most impact? What should we go after first? How many nudges should we implement, right? There's a whole host of nudges that are available to put into production, but where and how do we engage our providers, I think, is what we want to look at first. Query versus nudge financial impact. So again, you can still see, even at the outset, that the majority of the financial impact is coming from the manually generated queries or the or templates that we already have in place. But as we continue to add on those nudges, you can see the top white part of the bar graph is where we're seeing some of that incremental improvement by using the nudges, right? We're starting small scale and adding those as we continue to educate our providers, get the feedback from them, and really making sure what works. Of the enabled conditions that were available, looking at initially, right, we initially went live with heart failure, the type and acuity. That's why that small volume is there alone. And then looking at the different ones and their engagement that we initially saw from the provider. So just as you would with a manual query, there's a lot of education that goes into getting engagement and them answering that. And we didn't see anything different by utilizing the nudges. So while these are the proactive approach to get nudges or to get documentation on the record prior to doing a manual query, there is still some education and engagement initiatives that are necessary to be underway. This was the overall nudge status, and you can see here that while identified, a large number of nudges were naturally specified, prior to discharge, meaning that the CDI specialist did not have to follow up on it, nor did they have to generate then a separate query to potentially address something that was missing from the documentation there. We still have a large amount, you can see in red, of unaddressed opportunities prior to discharge. Again, an engagement element that's necessary with our providers in order to reduce that number of unaddressed. We want to make sure the chart is as clean as possible prior to the patient being discharged. So how do we continue to educate and engage our providers to address those nudges as they're getting them? This is just the nudge status per the hospital admission group. So you can see the types of nudges or the months that the nudges were provided, and then the resolution type that's there. Was the nudge resolved? Was it naturally specified? What were the volume of unresolved opportunities, or did the provider dismiss them, and so on? So you can see month over month, the number of opportunities has continued to increase as we add on and changed and made iterations to the nudges themselves. We still then, just as we showed in the previous pie graph, have an opportunity with the unresolved nudges. So how do we get our providers to answer them prior to discharge? Looking at the different triggers. So again, this just breaks out the volume of nudges that are being seen by our providers that are triggered by that technology that's available within the platform itself. And, looking through the number of opportunities and where do we have the biggest opportunity for education and engagement. This was, part of our Go Live group as well. And in partnership with our physician advisors, part of that Go Live group was our bariatric GI group. So maybe, again, a little different flavor that you may not think applicable to your institution, but something, certainly to look at. So again, you can see their volume of nudges, rightfully so, is a lot lower volume than you would expect with the hospitalist group. But true to point as well, where do we still continue to have opportunities that they are receiving the nudges? So there is opportunity for documentation improvement, and how can we month over month then improve their engagement with interacting with the nudge and resolving them prior to discharge. And then this is just the nudge type that were provided to the bariatric group. And you can see, right, heart failure in and of itself has a very low volume overall. Every once in a while, a new technology, an old problem, and a big idea turn into an innovation. So again, as we started with a quote, we thought that we'd end with a quote as well. That really summarizes kind of that implementation and go live and the efforts that have been put into VCU with the Engage One and prioritization project. So I think we have the opportunity to pause for questions and answers.
Yeah, we do. And thank you so much. This information has been super helpful, and I'm sure our attendees would agree. And one of our first questions is, does engage CDI Engage One work for outpatient? And I'll just take that one real quickly. Is we do actually have an inpatient solution as well. So if you are interested in learning more about either CDI Engage One or our other solutions, go ahead and click on that Contact Me button in the console, and we will follow up with you after. All right. So, and one other thing to remind people is if you want to download the presentation and your CEU, once you close out of the system, you're not able to get back in to download. So, while we're going through questions, go ahead and do that too. So, question on, can these nudges initially be directed to the physician for concurrent documentation to really alleviate the need for that query?
So yes, I think that's where we're moving more into that proactive space, right? We do like to kind of vet out the evidence sheet first on a CDI side, just to make sure that it's firing appropriately, and it's reading the documentation and all of the other contexts correctly. But the goal is eventually to have those nudges, and eventually they won't even need the nudges, right? I know, how long have we been asking heart failure queries? But eventually the idea is that they will see the nudge and go, oh yes, this will keep me from getting a query. So that is the goal, to move things more to that nudge space. And it works really well with kind of like an easy answer. Somebody once told me, like, the easy button, like, so think of it as that way. Those nudges that have easy responses are probably the best ones to have turned on.
Well, a good follow-up question from Denise from UVA asked, what strategy or approach did you use to determine which evidence sheets you enabled?
Sure. So that's where we sat down with our Solventum team, and they pulled all of our queries kind of over the past, I think, year or so.
Do you have an answer for that one?
Yeah. Can you hear me okay? So we sat down with our Solventum partners, and we looked at all of our queries over the past year or so and pulled out the kind of top 20 queries and lined those up to available evidence sheets to then determine which ones we wanted to turn on. And the idea there being, we're already used to asking these queries. So there, we know it's a documentation opportunity for our team, for our providers. And then two, it also gets the team kind of used to having that new workflow, right? Looking at the evidence sheet and linking it to the query. So having it not out of the norm for them, right? So that's where we worked pretty closely with our Solventum team.
What advice do you have for others considering this system?
I would look at partnering with your success manager and really talking through the options that are available to you in your organization. Also, right, just as we did for VCU Health, seeing if there's the availability to connect with other organizations that have already gone live with this, go through their, outcomes and trials and tribulations, as well as their success stories, to be able to share and make sure that this is the right fit for you.
Can you speak to the level of IT involvement and resource allocation that was required to implement this solution?
So I'm going to say this is a little bit of where that magic behind the scenes happens. I know that we definitely had our applications analyst involved, and then those on the electronic medical record side as well. But as far as how many resource needs you're actually going to have, Solventum can definitely give you all that information for you to take back to your team and see if it's a viable option for you.
What were some of the hurdles, or did you have any hurdles with physician education?
Yes. So I think, you could see it a little bit in the nudges, where getting kind of the adoption of the nudges and making sure they're keeping them visible has been a little bit of a challenge. So we're definitely going through and providing education and reaching out, making sure it's involved in our onboarding education as well. And even this week, I mean, we're, over a year out from go live of the queries. Even this week, we still had one physician who's like, I cannot find it anywhere. But I think we had the same type of thing when we moved electronic medical records too. So any challenges that you have now with your physicians, as far as, how do they find the queries? How do they respond to the queries? We don't actually get the how to respond as much as the problem, as how to find. And it's not any different than what we had in the electronic medical record. We just send them the screenshots, or we walk them through, this is exactly where you find it. And then they're usually pretty good from there.
Well, switching gears now to kind of the other side of the house, I find reporting CDI is a challenge. Has reporting been improved with this upgrade?
I'll start this, Emily, and then you can take over. So right, another opportunity for you to make sure that you're partnering with your Solventum success manager in order to help you through those challenges. It's not clear maybe what exactly you're struggling with when it comes to reporting, but there are some nuances, especially when it comes to the Engage One product and the reporting itself. I do hear, right, that there are some upgrades on the roadmap through Solventum to make improvements to the overall Engage One reporting platform itself. But again, right, just understanding where some of those pain points are and learning to use the reporting to share your outcomes is, where we've really partnered with our Solventum resources. Emily, anything else to add to that?
I'll say, for Engage One specifically, there is a whole dashboard in Enterprise Analytics, or I think it's called Analytics now, that calls out. That was one of those slides that showed the agreed and documented rate and everything for linked queries. And it gives a lot of information in that dashboard. So really sitting and taking the time to kind of go through it, and the Solventum team walked us through it, and it's like, this is what you need to look at here, and so that definitely helped as well.
Awesome. We do have one more question, but while we're asking and answering this, if there is any other questions, go ahead and put those in the Q&A now, because we do have some more time. Kay Merriweather from Tanner Health asked, were you able to decrease coding days and time of bill with your success in this space?
I do have to say the expectation of coding days is pretty high with all Ensemble clients. So they are looking to code that case within 2 days. Of course, there are extenuating circumstances that they're looking at. So I think with that tight timeline for our coding partners as well, that I think it would be harder to get that down even more. But yes, right? If we are using the nudges and the evidence sheets alone, that's adding to our concurrent query process, meaning that decreases the time of the retrospective, which would decrease the time to review and hold those cases on the back end. That I think is beneficial overall, not only from a CDI and coding and billing aspect, but also for our providers to make sure that that documentation is on the chart at the time the patient is in-house.
Great. Well, we did have a couple questions about the recording of this webinar, and we are recording today. So in the next couple weeks, we will be posting this on our website, so be on the lookout for that. Again, I cannot thank our speakers enough. This was a really great presentation, so thank you again. Whoops, one more came in and I want to make sure, let's get to this one. Evidence sheets seem to make a difference. What feedback did the CDIs give around the introduction of these sheets?
So I think that is going to depend on the experience level of the CDI, right? So some of them, especially, I keep going back to heart failure, but that's a forever query, right? So some of them were like, okay, I know all this. I don't need it to pull it together for me, right? And those were our more experienced CDI. And those that have less experience definitely probably gravitated to it quicker. So I do think that it definitely helps when you have a less experienced team. But then as we moved on to more evidence sheets that maybe weren't our top query opportunities, we found increases in queries in those arenas. So definitely in the beginning, some of them were like, why is this here? This is not helping me. But, as we walk through it and everything, it definitely has gained more traction.
And I think removing that manual process, right? To go back to find the notes and pull in the different information, where the evidence sheets have the ability to pull it all together for you. So decreasing the time it takes to write a query. We've also identified outside of VCU, but a number of other clients that are implementing this as well, that, and again, you don't know what you don't know, where evidence sheets were surfacing a large volume of malnutrition instances at one of the organizations, that not that the CDSs were missing, but they were pulling all of those different pieces together that said, oh, this may be an opportunity to query further around malnutrition. So again, I think leaning into the technology and taking some of that manual lift away allows for additional resources to look for the out-of-the-box query options, what's really going to drive change and maybe move that DRG in a different space, as opposed to the low-hanging fruit that I can let the system do some of that work for me.
Awesome. No, that was a great response, and I'm glad we were able to get that question in. So again, we very much appreciate your time and information from today. I think there'll be a lot of people going back and listening in. So thank you both very much. To our attendees today, we greatly appreciate you joining. Make sure you download and check out our resources. If you are interested in learning more about our solutions, go ahead and hit that contact me button. And then at the close of the webinar, if you could let us know how we did and complete the survey. So again, thank you both to our speakers. We really appreciate it. And we look forward to our next conversation and our next webinar next month. So thank you again, everyone. Have a great day.
Thank you.
Thank you.